Hello, everyone. Welcome to this session with me, Dr. Vyshnavi, your ENT faculty. And first of all, before I start the session, I'd like to know from all of you, how was your exam? How did you guys perform? Let's first de-stress. Let's just leave alone the recall on the side for the moment and let's just relax for a minute before we start the session. And if I'm audible and visible to all of you, kindly give me a quick confirmation in the chat box. So I hope I'm audible and visible to everyone. Yes, so thank you for the confirmation. So today we will be doing the recall, but before that, I'd just like to know your experience about the exam. How was it? As far as the initial information is concerned, I know that it was a moderate to a good examination only, not very, very bad, I would say. So I think most of you must have done fairly well. Am I right or am I wrong? Tell me quickly, how did you all do? Good evening, Farooq. Good evening, Nikhil. Good evening, Adarsh. Okay, so some of you are saying that it was easy. Some of you are saying that you didn't do so well. It's okay. Whatever has happened has happened. We'll just let it go by now because the time for examination is done. We don't have anything in our hands right now. So what we can do just right now is just hope, because hope is something that we need at the end of the day. So many miracles can happen. There can be things that you must have thought you've not done well, but you must have ended up doing well. So just let's pray and think that everything is going to go in our favor. Okay. So second part was not good. First part was easy. That's how it is, right? So generally one paper is difficult, one paper is easy. So it's okay. And you feel that that difficult paper is putting you down at the moment. But trust me, once you finish your exams, that's the feel that you get. But eventually you realize, no, I didn't do so well, so bad also. I must have done quite well. So I'm sure this is going to be the feeling that will come eventually tomorrow. So yeah, so let's just start the recall very quickly. So this is a quick disclaimer from PrepLadder that these questions are recall based, and we do not know the actual language of the questions. We do not know the actual options. Based upon the students' recall, we have given our feedback onto this PowerPoint presentation. So let's edit this. If there were any errors, please do convey to me during the session so that we can edit and give you the final one on the PrepLadder app, where you will get the final discussion that's going to be uploaded. Okay. Chalo, let's go without wasting any of your time. So the first question was, which vitamin deficiency leads to laryngismus stridulus? So it must have seemed to you a little, tricky question, क्योंकि हमने तो ये laryngismus stridulus हमने कभी पढ़ा ही नहीं था ENT में. I'm sure that many of you will agree that this is a new terminology that has come to you. I think this was the only bouncer that all of you must have seen in the exam, but I think it was okay for some of you to answer because first of all, laryngismus stridulus is a condition where in the name itself you have this stridulus, which means that the patient has stridor because of the spasm of the vocal cords, or there is an involuntary contraction of the vocal cords causing stridor. Now, this is specially seen in children with rickets. Now, the examiner wanted you to know that laryngismus stridulus is a condition that is seen in which condition? In which condition called as rickets. And now this rickets occurs due to deficiency of which vitamin? We know that deficiency of which vitamin leads to laryngismus stridulus? It is vitamin D. Okay, so I'm sure that even if you didn't know this that much, I think you could still probably make a guess, because vitamin K, vitamin A, and vitamin E have no role at all. Whereas vitamin D deficiency leads to rickets, where you see there is a muscular atrophy and all the other conditions that could result in, involuntary movement of the vocal cords as well. So I think other than that, the rest of the questions were pretty simple and easy. So let's go to the easy questions now. What is the preferred management for a pediatric patient? So they've mentioned to you very specifically pediatric patient with symptomatic adenoid hypertrophy causing chronic nasal obstruction and sleep apnea, right? Now the question is asking to you only this much. My question to all of you is, was there glue ear in your options? क्या ये वर्ड मेंशन था? एनीथिंग लाइक ओटाइटिस मीडिया विथ एफ्यूजन, एनीथिंग लाइक हियरिंग लॉस, वाज दिस मेंशन्ड इन योर एग्जाम? ये दिया गया था या नहीं? क्योंकि आंसर चेंज होएगा। आई वांट यू टू टेल मी क्या ये वर्ड्स दिए गए थे या नहीं दिए गए थे। आई एम वेटिंग फॉर ऑल ऑफ योर फॉर यू टू रिकॉल। ये वर्ड नहीं था, सो हबीब, दीपक, हैफेद, रोहित, all of you telling it's not there, while some of you telling it's there. So let's answer both ways. So if they had given to you adenoid hypertrophy, nasal obstruction, sleep apnea, and they did not mention to you anything about this was not there, then your answer will be just adenoidectomy. Because for sleep apnea, so if I take only sleep apnea, for sleep apnea, the treatment of choice in pediatric patients or in children, the gold standard treatment is adenoidectomy. And if they did mention to you about tonsillar hypertrophy, then tonsillectomy also. So your answer should be only adenoidectomy in this case. But if they have given you these three words, if this is there in the examination, then your answer will change to adenoidectomy plus Grome insertion. Okay, so plus Grome insertion. So we need to understand, was this what, did they give you this or did they not give you this in the options? So I want you to tell me. Mouth breathing है, ठीक है, mouth breathing is a part of nasal obstruction, तो ठीक है, mouth breathing was there. Hearing loss with mouth breathing, ठीक है, तो अगर hearing loss है तो फिर your answer is B, अगर ये नहीं था तो the answer is A. ठीक है, तो अभी दैट एम्बिग्विटी है, तो वी विल नॉट गो इनटू द निटी-ग्रिटी ऑफ इट कि कितना था क्या नहीं था. इवेंचुअली आई थिंक यू कैन जस्ट टेक योर टाइम ऑफ एंड ट्राई टू रिकॉल द एक्चुअल लैंग्वेज ऑफ द क्वेश्चन. अगर सिर्फ डिफिकल्टी इन ब्रीथिंग था, नेसल ऑब्स्ट्रक्शन था, माउथ ब्रीथिंग था, हाई आर्च पैलेट था, ऑल ऑफ दीज सिम्टम्स आर देयर ऑफ obstruction. So if it is only obstructive symptoms, then you will mark it as adenoidectomy. But if they have given you obstructive with any of them mentioning to you like hearing loss, not responding to commands, falling grades in the school, or having air bubbles, air fluid level, glue ear, otitis media with effusion, any of these buzzwords are given, then your answer will be both. Okay. Okay, so if patient increases the sound of the TV while watching cartoon, it indirectly means hearing loss. So अगर ये line था, तो then of course your answer will be adenoidectomy with Grome, no doubt upon that, because that's an indirect indicator to you that hearing loss है, इसीलिए बच्चा cartoon देखते वक्त volume increase कर रहा है. As simple as that. So sleep apnea अगर था नहीं था doesn't matter. If there is an obstruction and if there is hearing loss, your answer will be adenoidectomy with Grome. ठीक है? Snoring was there, very good. That also favors to us about sleep apnea. Okay. Just 1 second. I think the screen share. Yeah, I think now it's okay. Fine. What is the most commonly used test for newborn hearing screening? Ma'am, hearing loss था, wonderful. तो hearing loss था तो Grome डालना ही पड़ेगा. अगर hearing loss नहीं था तो then it is only adenoidectomy. तो ठीक है, आंसर तो हो गया वो. अभी चलते हैं. What is the most commonly used test for newborn? अभी यहाँ पे इन्होंने पूछा है what is the most commonly used test. They have not mentioned you screening test, they have not mentioned to you confirmatory test. ये दोनों words use नहीं किया गया है. So when they have not used screening or not told you confirmatory test, there can be some ambiguity in your head कि एग्जाम में क्या आंसर करूं, OAE आंसर करूं या बेरा आंसर करूं. बट अगर मोस्ट कॉमन है तो what is that test that is going to be used in general population to identify neonates who are born with hearing loss? It will be otoacoustic emission. So स्क्रीनिंग अगर मेंशन किया गया था तो गुड, अगर नहीं मेंशन किया गया था और मोस्ट कॉमनली भी पूछा गया था, देन द आंसर विल बी ओटो अकाउस्टिक एमिशन. बेरा इज अ कंफर्मेटरी टेस्ट दैट इज ओनली यूज्ड ऑन दोस पेशेंट्स हु आर रेफर्ड फ्रॉम ओए. तो इफ देयर इज अ पेशेंट हु हैज ऑन ओटो अकाउस्टिक एमिशन failed the test, then you refer to बेरा. So which will be performed more? Of course, it's going to be otoacoustic emission. So this was easy. So baby mentioned था तो OAE and Bera are used for newborn for baby, so it's still okay. Healthy baby also is okay. because all the healthy babies, all the children who are born at birth, as per the neonatal hearing screening program, every child who is born at birth should undergo otoacoustic emission test. So that's why it's a very widely or most commonly hearing screening test that we use in children. Okay, this is no controversy. Now let's go to the next question. What is the name of the staging system used in JNA? तो अभी JNA हर साल क्वेश्चन आता है, तो अब इसको ट्विस्ट करके पूछा गया था कि what is the name of the staging system that they have used for JNA? So typically the one that we use is the Radowski staging system. But I don't know if this was there in the option or fish classification was there in the option. So Radowski is the more popular one, but if they have not mentioned Redkowski's and if they have given you fish classification, then that is also your answer. Okay, so yes, so I don't know, some of them are telling fish, some of them are telling Redkowski. So if Redkowski's nahi tha, then it is fish. These are the two commonly used staging systems. So basically in fish classification, we have fourth stage also. In Redkowski's, we have only three stages, 1, 2, and 3. Fish is divided into 4 stages, where 1, it is limited only to the nasopharynx and to the paranasal sinuses. And the spinopalatine foramen, sorry. 2 is going to be involvement of the pterygopalatine fossa and the paranasal sinuses. 3 is your infratemporal fossa and the orbital involvement. 4 is going to be intracranial involvement with cavernous sinus, pituitary fossa, and the optic chiasm. So that's the brief classification. Redkowski's is just divided into 3. It is divided into stage 1, stage 2, and stage 3. 2 is divided into 2A, 2B, and 2C. 3 is divided into 3 and 3B. So we'll not go into the details of it at the moment because we just want to know the name of the staging system. We have this already recorded on the app about the staging classifications that are used for JNA. PNM is definitely not used because JNA is a benign tumor. It's not a malignant tumor. Ann-Arbor's classification is used for your Hodgkin's lymphoma. So again, that will not be your answer. Okay. Which of the following are symptoms of Greden-Egos syndrome? So can you all tell me what is the correct option for Greden-Egos syndrome? I'm sure all of you know this. All of you know this? This was not the question. Greden-Egos was not in the options. This was not the question. Okay, so basically, if this was not there, let's give it a quick skip. But anyways, if it was that, let me just quickly tell you, Greden-Egos syndrome is seen in petrositis, which is a condition where there is inflammation of the petrous apex seen secondary to any CSOM patient. So here they have deep-seated retroorbital pain because of fifth nerve involvement. Sixth nerve involvement causes lateral rectus palsy, and the cause is persistent ear discharge. So here the answer would have been ear discharge, retroorbital pain, and diplopia. But it was not there, so let's give it a skip. Identify the most common location of JNA. Was it option 1, 2, 3, or 4? So Nandi says petrositis was there. Some of you are saying petrositis was not there. I'm waiting for your answers. So basically, if you see, this is the area of the eustachian tube. So this is your eustachian tubal opening. This is covered by a cushion. What is this cushion called as? This is called as torus tubarius. Behind that, there is a fossa. This is called as fossa of Rosenmuller. And this is the posterior pharyngeal wall of the nasopharynx, where you generally have the adenoid tissue. Right? So here we are asking you, what is the most common location for nasopharyngeal carcinoma? What should your answer be? Yes. So answer is going to be option 2, which is showing to you the fossa of Rosenmuller. So fossa of Rosenmuller is the most common site where your nasopharyngeal carcinoma originates from. Okay, so I think most of you must have got this right. This is a standard question. This is sabko pata hai. The next question is also a pretty easy question. Which structure does the anterior ethmoid sinus drain into? So where does the anterior ethmoid sinus drain? Now the lateral wall of the nose is a standard question where you get a lot of questions coming in the exams. So here you will have to know what are the structures that drain into each of these metastases. So inferior meatus receives the drainage of nasolacrimal duct. The middle meatus receives the drainage of anterior group of sinuses, which is frontal, anterior ethmoids, and maxillary sinus. Superior meatus receives the drainage of the posterior ethmoids, and the sphenoid sinus drains into the sphenoethmoidal recess. So if they're asking you anterior ethmoids, it is going to be your middle meatus. Okay? This question was not there. Okay, if this was not there, there's somebody telling there was a question on anterior ethmoidal neuralgia. Was this there? So anterior ethmoidal neuralgia is nothing but your Sluder's neuralgia. So what is Sluder's neuralgia? So basically, whenever you have compression of the anterior ethmoidal nerve, so we have the anterior ethmoidal nerve which supplies the septum in the anterior and the upper half. So if we have a spur like this, what will happen? There is compression of the nerve, and that compression of the nerve presents to you with headache. So patient complains to you with headache. And how do we know it is Sluder's neuralgia? By placing a piece of cotton between the lateral wall and the spur that is soaked in xylocaine. What happens? The nerve gets anesthetized and there is a relief of pain. So that is the diagnostic test for diagnosing Sluder's neuralgia or anterior ethmoidal neuralgia, where there is compression of the anterior ethmoidal nerve, usually due to a spur that is impinging on the lateral wall of the nose. Right? Okay, so they had asked this question is due to compression on middle nasal septum, inferior nasal septum. What I mean, did they mention the location or what was this? This question wasn't there. No such question. Okay, so I am not getting the thing from your end. Did they ask you about anterior ethmoidal neuralgia or not? Second thing, did they ask you about drainage into the meatus? So is the drainage there? Not there. Now coming to the anterior ethmoidal neuralgia, it is due to compression of the anterior ethmoidal nerve, can be due to inferior and the middle turbinate. Most often it is due to the middle turbinate that is compressing than the inferior turbinate. Okay. Okay, so Nandakumar, now I got it. The if so senior option, middle turbinate or inferior turbinate. Most often it is due to the middle turbinate that is compressing the nerve because of the spur that is lying on the middle turbinate. Second, after that, I would take it as the inferior turbinate. Okay. What is the preferred initial management for a patient presenting to you with CSF rhinorrhea? Now here I think there was a little bit of controversy कि site पूछा गया था, halo sign पूछा गया था. What was it? Like, can you all give me a little bit more detailed explanation about this? What did they ask you here? So MUSIC is saying that what is the causes of anterior ethmoidal neuralgia? Is it compressed by the inferior nasal septum, superior nasal septum, middle nasal septum? वैसे कुछ था. Or did they ask you inferior turbinate, middle turbinate, or superior turbinate? What will be the management except false पूछा था. Fine. So basically, if there is a patient who requires a repair for CSF, now if they have given to you that there is a patient who's having CSF rhinorrhea, how do you manage it? Who accept agar question hai, so the first thing that you will do is you'll give bed rest. So this is definitely the treatment, initial treatment that you will do. Second thing will be antibiotic with acetazolamide. Why do we give antibiotic? We are giving antibiotic to prevent any secondary infections that could lead to meningitis. Acetazolamide is given basically to reduce the intracranial pressure. Diamox is the drug of choice, but yeah, acetazolamide also can be given to reduce the intracranial pressure. Now you have immediate surgical repair without initial medical treatment. This is something that you won't do. So I don't know if this was there in the option, because initial surgical repair without a medical treatment is definitely not what you do. You will give a medical treatment. If it fails, that's when you do surgery. Again, steroid and FES is not something that you would do for a patient with CSF rhinorrhea, because FES can be done if there is a leak in the ethmoidal region, But if it is a leak at the cribriform plate of the ethmoid, you don't need to do a complete functional endoscopic sinus surgery. So I don't know if this option was there or not. D option was not there. Okay, we'll remove D. HRCT of the paranasal sinuses. Yes, this is something that you will do to identify the site of defect. Okay, beta 2 transferrin you will do definitely. Which is not done पूछा था मैम. So अगर पूछा था कि not done तो medical treatment, without medical treatment you will not go for surgery, that is for sure. That is definitely not the thing that you will do. FEF is something that may or may not be done whenever you're doing a CSF rhinorrhea repair leak, because if the leak is at the roof of the anterior ethmoids, or if it is at the posterior wall of frontal or the roof of sphenoid, then you will have to do a FES to reach the site of defect. But if the defect is at the cribriform plate of the ethmoid, then you don't need to really do a FES to reach the cribriform plate of the ethmoid. So this is plus or minus, but without medical therapy, you will never go for a surgical repair. Yes. So if you had to choose, these are the two options which you will definitely choose from. Okay. Chalo. 45-year, yes, Nandakumar, A and D, both of them. If D option was not there, then we'll go for A. Okay. 45-year-old woman presents to you with progressive hearing loss that has been worsening in the past few years. Audiometry shows to you that there's a conductive hearing loss and the diagnosis of otosclerosis is made. What is the preferred surgical treatment for her condition? Stepidectomy, stepidotomy, tympanoplasty, cochlear implant. So पहले तो बोल दो कि ये क्वेश्चन था या नहीं था. Okay, I think somewhere it's getting stuck. 1 second. Yeah. Not there, ma'am. ऐसा क्वेश्चन नहीं था. It was a pregnant woman. ठीक है. Hearing loss was mentioned in the question. Worsening during pregnancy, fine. That is all otosclerosis. So music is saying option 1, foot plate erosion. Woman has 56 decibel hearing loss. Fine. That also supports to you for otosclerosis. ओके 56 डेसिबल तो ठीक है, बट ओटोस्क्लेरोसिस था, बट उसमें क्या पूछा गया? Did they ask you about the clinical sign like Schwartz sign? Did they ask you about surgical therapy? Did they ask you about pathophysiology? Did they ask you about sodium fluoride? Did they ask you about hearing aid? क्या पूछा गया था? Okay, there was a question on organ of balance. We'll come back there. So Varsha is saying that unable to sniff back the nasal discharge, what to do next? That is suggestive to you of CSF leak, that after trauma, if a patient is unable to sniff back, that is suggestive to you of CSF. Of course, initially bed rest, give medical therapy. If it fails, that's when you go for surgery. Okay. The question is, there is a patient whose pregnancy, after pregnancy there's hearing loss, 56 decibel hearing loss. यहाँ तक तो ठीक है. So this part is clear. 56 decibel pregnancy, hearing loss, all of this is in support of your otosclerosis. Now here the question is erosion with or without drum injury. So that first option is erosion with or without drum injury, right? Second option, ossicular impending with missing erosion. Okay, second one, ossicular fixation with intact tympanic membrane. Okay. Fine, this is the second option. Then do you have any other third and fourth option? Because I think this was not asked definitely. Okay, so basically in otosclerosis, there is both activity. There is an initial osteoclastic activity, followed by that there is an osteoblastic activity. So it's not that there is only excessive bony deposition happening. It's not the case. In otosclerosis, what is happening is there is a nidus, there is an embryological focus that when is triggered by hereditary factors or, for example, pregnancy, whenever there is a trigger, there is an osteoclastic activity that happens first, and this is followed by an excessive osteoblastic activity that results in excessive bone deposition. So the endochondral cell rests are triggered by something where it promotes the osteoclastic followed by osteoblastic activity. Now here what will happen is there is fixation of the foot plate of stapes. The disease is not in the tympanic membrane. So there is an ossicular fixation with an intact tympanic membrane. Now this nidus or this endochondral cell rests are present only in the foot plate of stapes. So that's why you're having that deposition around the foot plate. You don't have that at the tympanic membrane, which is why you don't see any erosion or osteoclastic activity happening at the tympanic membrane. So there is only fixation of the ossicle, and whenever the stapes is fixed, that's the only time when you get a maximum hearing loss of 60 decibels. Whenever there's a tympanic membrane perforation, the hearing loss that we usually see somewhere between 30 to 50 decibels. But when there is an ossicular fixation, you get up to 60 decibels of conductive hearing loss. So ossicular fixation with intact tympanic membrane will be your answer. I hope this is clear to everyone. No doubt on this. Okay. Next question. A patient with history of trauma presents to you with hearing loss. A HRCT scan was performed. Which of the following structure is not typically visualized on a HRCT? Cochlea, vestibule, semicircular canal, and organ of Corti. These were the four options. So first of all, whenever we're talking about a CT, abhi samajh lo ki you didn't know anything. Ye question pata hi nahi tha. Now we know HRCT is a investigation that you do to identify bony abnormalities, right? So when do you do HRCT? To identify bony lesions or bony structures, bony anatomy. MRI is something that you do for identifying soft tissue. Now, whenever they're talking to you of bony structures, is cochlea bony? Yes. Is vestibule the bony covering over the utricle and saccule? Yes. Is semicircular canal the bony covering over the semicircular canal ducts? Yes. But where is organ of Corti? So if we take the structure of cochlea, we know there are three compartments. We have scala vestibuli, we have scala media, and we have scala tympani. This scala media has got this organ of Corti. So this organ of Corti is a sensory neuroepithelium that is responsible for hearing, present inside the scala media. So it's very hard to define organ of Corti on a HRCT. Okay. There was no question like this. Okay, so there's some of you telling that there was a question about the balance, and they have asked you which organ is responsible for balance part. Was it semicircular canal? Was it cochlea? Or is it organ of Corti? Somebody is telling like this. So if they have given to you very clearly balance to sabko pata hai, it is by semicircular canal. Angular movements are sensed by the semicircular canal, whereas linear movements are sensed by the macula, which is present in the utricle and saccule. So utricle saccule to option mein tha hi nahi, to answer will be semicircular canal. Okay? So this is also sorted. So far, I think whatever questions were given to me from the students I have discussed, but if you've got any questions for discussion, please mention in the chat box. Semicircular canal, yes, it's the organ for balance. It has got no role for hearing. Hearing is only by organ of Corti, which is present in the cochlea. And for both hearing and balance is going to be your vestibule that contains the utricle and saccule. Right? So do you have any questions? So balance and equilibrium, सीधा question था तो semicircular canal ही answer होगा, उसमें कोई doubt नहीं है. Okay, any other questions that you recall of? So this is what I have been given so far. I think it was pretty easy from ENT point of view, except that they twisted it a lot. But I think going forward, we will have to take that note to us that questions will be from the topics that are repeatedly asked, but in a twisted format. So that's all that we need to work upon. We need to work upon, our ability to take MCQs. Once you've learned the theory, please take the test, take the Q banks from, whichever you want to, but do practice questions. In PrepLadder, we have clinically based Q bank, so that helps you to get a hang of the questions before you go to the final one. Yes, all are conceptual questions. So I think with this, I'll take your leave. If there's any other questions, please do leave it in the comment section. If you think there were any errors during the discussion, please do leave it in the comment section. We will go through the feedback very seriously and give you the right questions with the right options, hopefully in the app, so that you have that PYQs and the PYQ discussions for the next set of students who will appear for the examinations. So thank you for logging in and helping me with the recall questions, and hope you all have a good time. Take rest, sleep well. What is done is done. Don't take too much of pressure. What will happen is bound to happen. You've done your best. So I'll take your leave for now. Take care and bye bye.